Autogenic drainage is an airway clearance technique using controlled breathing in 3 stages, at different lung volumes to loosen, mobilise and move secretions to the central airways. It should be prescribed by a healthcare professional with expertise in the teaching of this technique. Nebulized mucolytics may be used before or during the session. Autogenic drainage is generally suitable for people over 8 years of age who have chronic respiratory disease and moderate to large amounts of sputum. As no equipment is required, it enables a cheap, portable and independent airway clearance therapy. If bronchodilators have been prescribed, administer them before commencing treatment with this technique. The technique can be used in any position, but is generally taught in sitting. Sit in a comfortable, well-supported chair with the neck and shoulders relaxed. As this technique requires an open glottis, expiration should initially be taught with the mouth open, which enhances auditory feedback. Some patients may find it beneficial to use a piece of wide-bore tubing placed at least 3 centimetres into the mouth to assist with the opening of the glottis. Breathe out with the glottis open, down into respiratory reserve volume. Once breathing out through the mouth has been mastered, more experienced patients will progress to breathing out through the nose with the glottis open. Starting with low-volume breaths from expiratory reserve volume, breathe in slowly, hold the breath for 2 to 3 seconds, then breathe out until secretions are felt or heard gathering in the airways. This may take a number of breaths.
Mouth just a little bit open.
It may be beneficial for the therapist or patient to use proprioceptive feedback by placing their hands on the abdomen to ensure low-volume breaths. During the 3 stages of the technique, the hand will follow the level of the breathing. The expiratory force must be controlled in such a way that the expiratory airflow reaches the highest possible velocity without causing early airway compression. Patients with dynamic airway collapse may only need to breathe out with a relaxed sigh. Patients with more stable airways may need increased expiratory flow. Once the sputum is heard crackling at low-volume breaths during the last part of each expiration, move to larger tidal volume breaths, continuing to breathe in slowly until the sputum is heard or felt to collect.
Keep that throat open.
This may also take a number of breaths. Finally, after several breaths in the inspiratory reserve volume range, the collected mucus reaches the upper airways where it can be cleared by a high-volume huff and cough. At all stages, the patient must be encouraged to suppress their cough until the sputum is in the large upper airways and ready to be easily expectorated. One of the many benefits of this technique is that less effort is required to expectorate, which reduces stress on the pelvic floor and decreases other side effects related to excessive or paroxysmal coughing. The 3 stages of the technique should be repeated until the lungs feel clear. The patient should be given written instructions, including the technique and prescription.